With that, we better go to questions. Go to the audience. Chip, quickly, have to be on mic.
As a contributor,
Could you identify yourself?
Chip Kahn with the Federation of American Hospitals, and I am a contributor making the problem worse. I just would like to make a point of that I think for the record, which is, at least from the view of the hospitals, the productivity adjustment is really nothing more than a cut that was part of our contribution to being able to make the whole thing happen so that we could pay for the additional coverage. At least from the hospital industry standpoint, there never was any kind of illusion that this was some kind of standard that we could meet in terms of improving quality, despite the fact that MedPAC writes it in every year. It's based on a BLS statistic that has nothing to do with hospitals. But on the other hand, we felt strongly to make this all work that in terms of coverage, it was worth the contribution. And I guess it's just too bad that the Congress, in its wisdom, when it wrote the law, didn't decide to actually change the job of the trustees. Because what they should have done was put all of the new entitlements into the same basket and then ask for a report that showed the effect on the health system of all the entitlements. Because basically what we've done here, and with all due respect to the panel, is we've taken $500x billion and the added revenues, $500x billion from entitlements, current entitlements, $500x billion from various revenues, some of which affect entitlements, and we've transferred that over to Medicaid, new Medicaid recipients, and to new covered Americans who'll get significant subsidies. That's the 30 million. And we thought that was a good thing, but that wasn't about reducing health care costs. Although there are things in the bill that hopefully will reduce health care costs, that was about getting all Americans covered. And I think if we made that clear in the dialogue, then we can get on with the next part, which is, boy, health care is expensive, and maybe we ought to do something about it. But that wasn't what that discussion was really about, even though there was some allusion to it in the discussion.
Yeah, I'd like to comment on that briefly. And I've been hoping to bump into you sometime, Chip, because I wanted to ask you the question. I fully understand what you're saying, that there was the agreement, the negotiation between the hospital industry and the administration and Congress, and where you all basically said, yes, we can scale back, we can economize, and in exchange, we're getting many more patients with insurance, and it'll all work out. The thing I wanted to ask you was, over the next 10 years, roughly, you'll get the more patients with the insurance, and you'll give up some payment rates. In the next 20 years after that, or the next 10 years after that, and the next 10, et cetera, you're not getting the extra patients, but you're still getting the productivity adjustments.
You're always... I guess maybe I'm missing something. I mean, the incremental uninsured, if you don't do something about it, it would carry off into perpetuity also. So you're getting the extra revenue from reducing your bad debt, uncompensated care, as much in perpetuity as anything else, I think. Now, you could say, did you make a bad deal? And fortunately, I don't think I'll probably be working after 2020, so we don't have, maybe I will, but for somebody else, maybe.
No, my point, Chip, was really that the deal you made was for 10 years, and I would refer to it as a level shift.
Right. Well, but beyond the 10 years, at least in theory, we don't know what will happen in fact. The subsidies and the Medicaid, the new Medicaid recipients, will still be there. I mean, so that you're going to have universal coverage or tantamount to it in perpetuity. So I guess maybe I'm missing something in your question. That's one of our assumptions.
Right. Your additional patients, you get 34 million more people with coverage.
Right.
And that will grow gradually with the population, about 1% per year. So you get more patients over time, and they've got insurance, and that's a good thing. Your costs don't change by that same kind of level. Your costs go up exponentially, and what we pay you through Medicare will go up by the 1.1% per year, and that grows and grows and grows. That's a growth effect versus a level shift effect. That's what I worry about on your behalf.
Yeah, I understand, and glad my contract only goes another 6 years. And then
And of course, that was true for the hospitals, but that same explicit agreement did not occur